welcome all of you to the third lecture in the Ungerleider Palliative Care lecture series. I have the honor of introducing our speaker today, Dr. Andrew Lasher, who's a friend and mentor to me. I'll go as far as to say he's one of the main reasons that my father and I, my father who's here, Stephen Ungerleider, initiated the resident palliative care education program here at CPMC, of which this lecture series is a small part. And as some of you may know, I trained here in internal medicine. During that time, I had the opportunity to learn from Andrew and watch how he artfully engaged patients and families going through incredibly difficult times, often in crisis around the end of life. And over, I saw his efforts as a very skilled palliative care physician truly change the course of their lives and make a tremendously positive impact on how patients lived and how they died. I wanted to make sure that all of the physicians in training here had the opportunity to be inspired, as I was, by Andrew and the entire palliative care team. So a little about Andrew Lasher. He received his medical training from the University of Texas Health Sciences Center. He completed residency in internal medicine at Stanford Hospital and Clinics and a fellowship in palliative medicine also at Stanford and the Palo Alto VA. Here at CPMC, he had many jobs. He was the director of palliative medicine, the hospital's internal medicine residency program director for a time, as well as the vice chairman of medicine. Today, he's come all the way from Nashville, Tennessee, where he currently works as the chief medical officer of Aspire Health, a home and outpatient-based palliative care company. So with that, I'll give you Dr. Andrew Lasher.
Are we good to go here? He actually had the nerve to ask me if I wanted to stand behind the podium. Anybody who's ever heard me speak knows that I am a wanderer. We good to go? Excellent. Shoshana, thank you so much. It is an absolute pleasure to be here. I am currently on vacation with my family. This is a wonderful excuse to come back and see a lot of old friends. I love the opportunity. Because I'm on vacation in Northern California, I didn't even bring a sport coat. So you definitely have to put up with casual Andrew today. No formality here. I think I need to say at the outset, and I'll look right in the camera as I say it, that I am the Chief Medical Officer of Aspire Health, and I definitely have a financial interest in the company as the Chief Medical Officer. I hope that doesn't make it feel like I'm pre-biased about anything. The truth is most of this talk is not really about anything commercial, although it is a lot about the finances of palliative care. And I want to be able to talk about the finances without anybody in the room wondering that that's all that it's about. It's one of my great worries is that we talk a lot about the money and what drives, how and why and when we care for people. It clearly isn't about the money. This is a wonderful thing to do. I'm going to first state the clinical case for moving care that's historically happened in a hospital, further upstream and out of the hospital. I'm going to talk about first the clinical case, then the financial case, and then try to yoke everything together to give you an idea of where I think the future's going. Anybody who's heard me talk knows that I'm pretty interactive. I will try to scoot through so we can leave plenty of time for questions. I love the Q&A section, but if you have something that you just can't wait to ask or you have to get out of here because we started late, just raise your hand or speak up, and I'll try to stop and find times to answer the questions, okay? So I called the talk Back to the Future. I almost called it the little black bag, right? Because that's where medicine's going again. It used to be back in the day that the country doctor would wheel out to see a sick kid or a sick elder with their black bag, and that image was sort of seared on the American mindset. And then as medicine developed, as we developed antibiotics and hospitals and surgical technique and chemotherapies and intensive care units and all of these things, there was a very profound shift away from the little black bag. So it's interesting that in this era of value-based care, that things are coming back around to that, albeit with a twist. So hopefully I can walk you through some of the ways this is happening. So I suspect a lot of palliative care friendly people in the room. You've probably heard various speakers start with this, right? The million-dollar question that any clinician, physician, nurse practitioner, chaplain, social worker, they've gotten this question, right? How long do I have? Somebody's been diagnosed with a life-limiting illness. They know it's serious. So they want to know. And as you think, I've often asked a variety of audiences just to muse for somewhere between 5 and 15 seconds about what would be important to you during this phase. Right? Some of you may have even had me ask you to do that before. So take 5 seconds. We'll move forward. It's a quick talk. And think about the things that are important to you at that stage. So without picking on people in the audience, right, most of the concepts that people raise come around pretty quickly to the same things. It doesn't matter if it's a doctor audience, a psychologist audience, a nursing audience. It doesn't matter, right? It can be the custodians, because they'll all say the same thing. What I want is to be out of pain. Usually people talk about pain first, but we know as providers there's lots of different ways that people can physically suffer. Right? They can be short of breath and anxious and depressed. All sorts of things can come up. People want spiritual peace, togetherness. They want to feel closure, meaning in their lives. They want to be surrounded by the people that love them and who they love. They want to have the chance, I think, to say the things that are important, right? Those 5 things that Ira Byock talks about. The I forgive you, forgive me, thank you, I love you, and goodbye. It's really consistent when you talk with people. The other thing that's consistent when you talk with any audience is what they don't talk about. Right? So, let's picture Hawaii, right? Let me tell a little story. I had a patient, I don't see Kevin Knopf here. I think he'll probably sneak in at some point, I hope. It's always a bad sign as a palliative care physician when someone consults you the minute somebody's diagnosed. Now, I understand realistically that we all want palliative care to begin early, but when an oncologist, sorry Bert, calls you the moment that somebody gets a diagnosis, you know that you've got to strap in. And this case was really tough. It was a woman who had metastatic lung cancer, symptoms for about 3 months. Nobody listened to her. Her doctor, not her oncologist, but her doctor had kind of blown her off. Totally healthy Marin County lifestyle, right? You know, all the macrobiotic food and all the exercise. She looked like she was probably 45. And not fair. It's not fair. 68, I mean, that's how old my parents are. I think you'd be pushing it to call it a tragedy, but it's early, right? We see it, right? You start to see people at that stage. She went through all that you go through, right? The carbotaxol, the second-line therapy, I can't remember what it was, probably Alimta back then. She wound up going to an academic medical center, you know, getting a second opinion that really basically didn't tell her anything new. And there was one hope for third-line therapy. She really wasn't doing very well, wasn't a great candidate. She got the therapy. It went really horribly. She felt terribly. And I remember her looking at me in the hospital, the last place she wanted to be. Her family, all this. She's like, why didn't I go to Hawaii? Right? Why didn't I go to Hawaii? Right? The family had a timeshare there. You know, and that was a place where she had just loved. You know, why didn't she go there? I've kind of thought about that question a lot. I don't know what the answer is. I think that the best answer I've heard is that the end of life, whatever period of time that is more about being than it's about doing, which I think makes sense. But still, I think metaphorically it means something. Very few people go to Hawaii, right? Whether literally or metaphorically. What do they do instead? Right? So they see doctors. Now, I've done that little question and answer thing. What are you thinking about in that last chapter of your life? Nobody's really talked about doctors. Every once in a while somebody will talk about propofol if they're a doctor, like because they don't want to be there. I guess in theory, like that requires a doctor unless you have access to a black market. But nobody really talks about all the things that are frankly more common for people at this stage. Being in the hospital, going in and out of the emergency room, getting poked and prodded, wake up, it's time for your sleeping pill, being in the intensive care. All these concepts are not really what people think of. Yet, if you look at it, right, the familiar thing, this is where most people in that chapter wind up. It's not all bad. Right? I don't want to suggest that all those things are bad. They're not bad. They're very timely and useful on occasion. But you have to acknowledge that there is a gap between the 20 to 25% of people who actually die at home and the 75% of people that say they want to. Right? There is a massive gap there. Now, some of these people may change their minds, and sometimes it's unpredictable, and I'm not suggesting it has to be 75%. But I do believe very confidently that there is a gap here. All right? So what are the reasons why that gap exists. Right? Why do people not metaphorically or literally or in any sense go to Hawaii? Why do they go to the hospital instead? Right? Or in greater and greater numbers, the nursing home. Mostly not because more people are winding up out of institutions. Frankly, the hospitals, as you guys are probably aware, help get people out of the hospital and into a nursing home so they can die there instead. Right? So that's not an ideal number. So why does this happen? So just to walk quickly through what the end-of-life experience is, not in the last days, but in the last months for most people in this country. Right? So the average number of doctors that people see in the last 6 months of life is 10. Now, I mean, I'm helpful, right? Like, I'm a good doctor. But I don't know that that's a good thing. Like, more doctors at the party is probably not what's best for most of these patients. They might have a PCP and a hospitalist and an oncologist and a couple of nephrologists sitting over there. They might see more than one nephrologist. You guys might see them together, right? And we're all, exactly, we're all valuable, right? But I don't know, one for each liver. Where did Hania go? So you get out of the hospital long enough and you forget all the details about paired organs and stuff like that. But people spend a lot of time in the hospital, a lot of time, and this is not custodial care, this is skilled nursing facility care, right? That's Medicare time, where they're in theory rehabbing, right? So a lot of time in an institution. So the statistics back it up. I'm sorry that the citation got dropped, but we've known, as we've known for decades, that symptoms, by and large, are not perfectly managed at the end of life. Probably can't be perfectly managed, but they could be better managed. Right? Cancer patients report pain that isn't treated well. Much more prominent in a lot of organ failure diagnoses, where people with COPD and CHF have massive symptom burdens. Right? And that gap doesn't seem to be closing as quickly as we'd like it to, given how much palliative care has penetrated the care landscape. Right? You'd think with all these really well-meaning, sanctimonious palliative care docs that we'd be doing a better job controlling pain. But things don't seem to be better. Right? And the other piece that I think is worth mentioning is that people who, by and large can tell you what they want, they're either not being asked what they want, or they're not recording it, or even if it's recorded, it doesn't make its way to the people who could do something about it. Right? So how many of us have seen DNR orders come in on hospital day 4, right? When somebody's on pressure control. Right? Like, we've all been there. So a lot of chaos, a lot of confusion, as I say, around these patients. On top of that, now let's segue not so artfully into the money. All right? It's really expensive. So looking at California, I kind of went California on these slides. It's been nice to be back, right? Listened to some Joni Mitchell a couple days ago. It was good. California, very expensive. $88,000 in the last 2 years of life. That's a lot. Right? About 1/3, 2/3 typically. So last 6 months of life is over half of that. Right? You look at commercial Medicare, where frankly the data is a little bit better. The average Medicare population in that period of time costs between $53,000 and $71,000, depending on geographic adjustments. Right? That's crazy. Now, again, all of that may be reasonable. In fact, spending more money at the end of life is probably what we ought to do. It's an important time. We just need to get better return on investment, right, is what I think. There's lots of things that we could do with that money, I think, better, and hopefully I'll paint the case for that. So you look at not just on a government spending or insurance company spending basis, it's actually pretty expensive for patients too. This is what they don't tell you, right? Like, everybody who was here with me in my role as a residency program director, as a palliative care person, you remember I used to beat you up about the money, right? The cost of copays and things like that. Well, they're expensive. That's a lot for people on fixed incomes. Right? I couldn't get the data for California, but looking in Tennessee, this is a lot of out-of-pocket money for people that don't have 2 nickels to rub together. Right? Very expensive. And almost half of people, basically, their debits from health care exceed their total assets. Right? That's not ideal. Right? Again, I always used to say, Linda and I say it all the time, right? It's a rainy day. Yeah, right? Got to spend it. Like, but it's a lot. So all told, I think we can acknowledge that care in that last chapter, improving though it might be, is expensive, poorly coordinated, often doesn't match with a patient's stated goals and values, and really just doesn't succeed on most of the fronts we'd like it to, not as much as it should. Right? And I think that, as I'll hope to paint the case, One of the reasons for that is the lack of good upstream palliative care. Right? When I say upstream, I mean not in the last days of life or even weeks of life, but the last months of life. But let's get more specific. So outpatient care, right? So what's the challenge here? So primary care doctors, a lot of our business is built around talking to primary care doctors. And they kind of get it, right? They kind of understand. They know these patients are tough. But here's what I say to them that makes them really step up and understand who we're talking about. I said, so you're going to basically manage this person's diabetes. You're going to close whatever quality gaps your organization is asking you to address. You're going to do very compassionate and thorough advanced care planning, right? You're going to do that in 10 minutes, right? Get it all documented, wrapped up with a pretty bow, and then that way the hospitalist, when your patient goes in the hospital, won't complain that this is something the PCP should have taken care of, right? Right? So in reality, these are patients, you have a 10-minute office visit for somebody that it takes 20 minutes just to get in the room. Right? So it doesn't make any sense. There's a great mismatch between what these patients need from the physicians that have often known them the longest and what they have the capacity to deliver. It's not just that, but that's a big part of it. The other piece, quite honestly, as people get sicker and begin to see nephrologists, oncologists, other specialists, they really move their focus from their primary care physician to the new specialist. It's not atypical and usually isn't unreasonable. These are complex illnesses. So, when patients begin to cycle in and out of the hospital, the communication hasn't always been there. I understand that Epic has come in and fixed everything, REA, that there's seamless communication and sharing of information as there should be. But it still isn't always easy. And frankly, there are some things that people aren't either capable or as talented at doing. And one of the reasons we have jobs in palliative care is that we're really good at talking about this stuff. We can frame it in a way that people understand. So it is a skill, and it may or may not be a gap, but I think we have a valuable skill that not everybody has. So the hospital has challenges too, right? Treat them and street them. You know that. The average patient was in the hospital during an admission for weeks, 40 years ago, many days, and now, I could probably ask Dr. Wiviat, what is the average length of stay on a medicine service here?
Target is about
3.5 days is the usual Medicare answer. So by the time you get somebody stable, then you're going to do all those things I mentioned. It's tricky, right? So palliative care's problem, although I know Catherine and her team have really fixed this, is what we used to call the rule of thirds, right? What that means is when you're a palliative care consultant in a hospital, a third of the people that you see die in the hospital. A third of the people you see you send right to hospice. And then a third is this big other. Right? They're a very confusing, difficult, unwieldy group of people that I think needed a different solution. But by and large, what it really meant was that the palliative care folks were seeing people very late in the game. Right? Hospitals also understand the concepts of value-based care, but let's be real, they're still built on admitting people to the hospital. Right? So a lot of what upstream programs do is reduce hospitalizations, and eventually that might be something the hospital has an interest in, but today, that's not still the currency of the realm. So there's lots of reasons that the hospital struggles with these patients too. Home care, another good program. I don't know if we have any home care people here, but their challenges are that they're pretty problem-focused by and large. As I'll talk about Sutter's Advanced Illness Management program, it kind of put a twist on home care that gave it some muscles that we'll get into. But most traditional home care is really about wound care. It's about physical therapy. It's about rehabilitative goals. And a big picture process is really not what they're after. Their staff may or may not be comfortable with the things that we're talking about. And they have what I refer to as an itchy trigger finger. That means that as soon as someone gets sick, kaboom, right? It's like the nursing home. Please do not pass go. Do not collect $200. Go right to the emergency room. All right? And on top of that, as a nursing-driven program, it often doesn't have the ability to intervene on various problems. So if that patient's getting a urinary tract infection, they may or may not be able to do something about it until everything has fallen apart. Hospice has its challenges, gets people too late. The average length of stay in hospice, I don't know what it is in California, but in the country, it's usually teeters around 18 days. So you can imagine in that last year of life, there's been a lot of water under the bridge up until the last 18 days. For cancer care, the average patient is on hospice for, I believe, nationally 11 days. So really too late in the game to make a major impact on the quality of care or, frankly, the finances. And they have a lot of other limitations, too. Their staff may be super comfortable at treating for comfort, But if they have a patient in active heart failure, they may or may not be comfortable managing that heart failure, not with morphine, but with afterload reduction and Lasix. They may or may not be comfortable with a cancer patient who's on a regimen that might cause neutropenia and what to do about that if they're febrile. Right? These are mismatches. So what home-based palliative care can offer in theory, as I hope I can paint out, is expertise in symptom management, talk about the big stuff, a whole lot more time, programs built around visits that last an hour or an hour and a half, not 20 minutes. Urgent care availability, which we'll talk about as a really critical piece of the whole equation. The ability and willingness, more importantly, to manage those pesky controlled substances that many people need in that last stage of life. These are all very important things that can provide an adjunct to all of the different services that we've talked about so far. And of course, the care planning, the care coordination, connecting back with physicians and with hospitals to make sure this does come off for the patient and the system as seamless. So it wouldn't be a palliative care doc if I didn't sort of show this motif, right? The whole idea being that the old system, which we take to mean the bad system of life-prolonging care until the very end of life, right? People are getting cheat in the hospital over and over and over again till somebody recognizes that the patient is dying. Right? It might be the doctor, it might be the nurse, it might be the family member, it might be the custodian, but somebody says, this is not a person that's going to get better. And then all of a sudden, it's been live, and now it's die. Go to hospice. Right? That's how it was branded. Right? You can imagine that's why hospice wasn't super popular. Right? Not hospice branding that, but I mean, it's like, well, you go to hospice. They'll, let you die. Right? Only the trick is nobody will ever love you for what you don't do for them. Right? You've heard that expression. So what palliative care has tried to establish, and I think this is a pretty well-known thing, is that most of our goals do not change immediately. Right? They transition. Like right now, I'm pinned to the left arm of this. Right? Like I have 3 young children. If I have a heart attack up here, please resuscitate me. Take me to the unit. Cool me if that's the right thing to do. Right? I'm cool enough, but maybe I got to get down to 34 degrees. All right? But as I get older, sicker, more frail, deal with more chronic illnesses, then my goals will, over time, transition. And they will not be all life-prolonging, nor will they be all comfort. Right? It's like I used to talk about being from Texas. It works better in Tennessee, right? This is a beer or tacos argument. Right? I would like beer and tacos. Thank you very much. I'll have the beer with the life-prolonging care, the tacos with the comfort care, and it's a really good meal. Right? And in theory, over this transition, people will be able to make a transition to comfort at a more appropriate time. And that is, in fact, what it's shown, as I'll share. The question is, how long? Right? And this is where we're going to get a little bit detailed, because palliative care people will always tell you that palliative care begins at diagnosis. I've heard that 1,000 times. It begins at diagnosis. They repeat it like a mantra. And I believe it. If I could only get someone to pay for it from diagnosis, then it would be better. But realistically, you have to think about when will your intervention, whatever that intervention is, if you're going to get someone to pay for it, whether it's a hospital, whether it's an insurance company, whether it's an accountable care organization, whatever it is, you've got to be able to promise them that it's going to be cost-effective or value-based. So we'll talk about what the ideal time is. I have my thoughts on it, even if I don't necessarily. Jennifer Beachy, it's good to see you. Come on, we're among old friends. It's really good to see you, Jennifer. So in palliative care, this big study came out about 5 years ago. You talk about a mantra. People were waving it around like the Bible, right? Come on, my oncology friends. Kathy, I saw you walk in the room. You know this one. Metastatic lung cancer, right? Some smart people at Harvard basically assigned an outpatient, mostly clinic-based, but a little bit home-based intervention for patients who'd been diagnosed with metastatic non-small cell lung cancer. I believe it's still, although I know there's great changes afoot in chemotherapy, I think it's a median survival more or less of 11 to 12 months. It might be a little longer now, but that's what it was then. And receiving this intervention meant you had focus on your symptoms, but also all the rich, creamy care planning goodness that palliative care folks do. Right? And what resulted was general overall well-being was considered better in the intervention group. And they were self-reported feeling better. Much less depression, which is remarkable in a sample like this, given how minimal in many ways the intervention was. It wasn't powered for cost, but looking at every sort of indirect measure of cost, meaning how aggressive care is. Chemotherapy in the last 2 weeks of life, the absence of hospice care, or a very short hospice stay. all these things were a lot less common in the group that got the palliative care folks talking to them, right? Working with them, managing their symptoms and all of that. All right, we'll come back to that because I think other people were doing studies similarly at the same time. This is at MD Anderson, right? Very high-tech, advanced, making cancer history. That's their slogan, right? Well, they've also got supportive care. They don't call it palliative care. You'll notice that people try to run very far from the P word, and then we'll create a new word, to be supportive care, and then they'll run away from that, and it'll be a big game of cat and mouse. I'm not sure what we'll finally settle on. But basically, in a similar population, albeit one with a variety of different cancer states, people did better in every domain, right? Did better. It's great. But here's the thing, right? In the group that was studied in Boston, with palliative care, they lived almost 3 months longer, right? Now, palliative care folks, again, they carried this study around like an axe, right? Like, I mean, here you've been saying all the time, making jokes behind our back, not behind our back, you make jokes to my face. It's like, here comes Dr. Kevorkian, right? Like, we've all been there. But the truth is, as we've always suspected, there's other good data that comfort-focused care does not cost people time, and if anything, it provides people more time. So this study was done in 2007, looking at all these different disease states. There was no evidence. Now, listen, I know there's some methodology people in the room. Of course these are not randomized, right? There's some studies you will never be able to do. That feeding tube study for dementia patients, right? Like, nobody feels ambivalent about feeding tubes. You either really want them or you really don't, so you wouldn't be randomized to it. I've always wanted to do a mouse model for fibromyalgia, like a mouse that just kind of sits, but it's never going to happen, all right? So you can't have that kind of a study. But from everything we can tell, right, hospice, if anything, you look at these curves, prolongs life for these advanced disease states. So for a sick population, there's starting to be the undercurrent of acceptance that a palliative intervention, even if you don't want to call it that, right? There's no evidence that it shortens a patient's time on earth. And there's good evidence, not randomized, double-blind, controlled trial, gold standard evidence, but good evidence that it prolongs life. So this is pretty cool. I don't want to wield it like a cudgel, but I do want people to be aware of it. Because a lot of folks, didn't understand what this meant, or were picking apart the methodology, but you'll notice that a lot of the big cancer centers that are doing clinical trials, they now have palliative care interventions, right? Because it's a simple thing you can do that, let's be real honest, if you're studying a new drug, is going to make it look good. Because if palliative care were a drug with that sort of survival benefit, it would probably be on the front page of the Times, right? Like, it's a big deal in oncology literature to provide